Hey guys, I hope I'm live and audible. So we are continuing our series on frequently asked and regularly repeated exam questions. And today we will be talking about the cardiovascular system. But before that, I have one question to address from the previous session, that is respiratory medicine, that is respiratory failure. I'll take 5 or 6 minutes to discuss respiratory failure and then we will start with the cardiology for today. Okay. So we'll begin with respiratory failure. Now, this is usually going to be a 5-mark question or maybe 3 marks, unlikely to be a 10-mark question. So, for a 5-mark question on respiratory failure, what all points I should write, right? So, first we will begin with definition. What definition we should write for respiratory failure? It is very easy to remember what is respiratory failure. When you think of respiratory failure, think of functions of the respiratory system. What are the functions of the respiratory system? To take the oxygen in and eliminate the carbon dioxide from the body, right? Inhale oxygen, exhale carbon dioxide. That's a simple thing. So when respiratory system fails to do one of these or both of these, we will call it as respiratory failure. So the definition we can write is impaired. There are only two functions of respiratory system: oxygenation of blood and carbon dioxide clearance. If there is impairment in oxygenation, impaired oxygenation, or if there is impairment of carbon dioxide clearance or both, then we will call it as respiratory failure. Then we will call it as respiratory failure. As simple as that. So that is our definition. If oxygenation failure has happened, then in that case, the blood oxygen levels will be low, right? What we call as partial pressure of oxygen, or your saturation of oxygen, SpO2, will be low. And in case of carbon dioxide clearance failure, blood carbon dioxide, that is partial pressure of carbon dioxide in the blood, will be high, right? Okay. So now they are going to ask you to explain briefly the types of respiratory failure. So the next thing we will address is types of respiratory failure. And when we talk about types of respiratory failure, we should write the ABG findings in that particular type of respiratory failure. And then we should at least mention 3 to 4 causes. Okay, so types of respiratory failure. So we'll start with the first one, which is type 1 respiratory failure. Type 1 respiratory failure. This is the most common type. This is the most common type of respiratory failure. And this is also known as hypoxemic or hypoxic respiratory failure. Hypoxic respiratory failure. So that means, what is the problem here? Is it carbon dioxide clearance failure or blood oxygenation failure? It is the failure of oxygenation of blood. Failure of oxygenation of blood. Oxygenation of blood. What can be the causes? The causes for type 1 respiratory failure. Anything that affects the respiratory system, right? If a name of a disease comes to your mind, you can write it as a cause for type 1 respiratory failure. Okay. Where the oxygen gets exchanged with the blood at the level of alveoli, right? Anything that affects the alveoli can cause impairment in oxygenation. Anything that obstructs the airway, oxygen may not be able to reach the alveoli, that will cause impairment of oxygenation, right? So the first and the most important cause that we can mention is pneumonia. Pneumonia. Second, acute respiratory distress syndrome or ARDS. Then third, pulmonary edema because of whatever cause, maybe cardiovascular or non-cardiovascular cause. Okay. Then fourth, drowning. Then fifth, pulmonary embolism. Pulmonary embolism. What is pulmonary embolism? The clot formed in the veins, mainly in the lower limbs, travel through the veins to the right side of the heart. From the right side of the heart, it goes into pulmonary artery and gets lodged in one of the branches of pulmonary artery. We will call it as pulmonary embolism. In that case, why there is hypoxia? Let us say this is an alveolus. The blood comes to it from pulmonary artery, then passes through the capillaries, and then goes into pulmonary veins to go to the left side of the heart. This is pulmonary vein, this is pulmonary artery. If there is embolism and a clot gets lodged here, then even if oxygen comes to the alveoli, blood is not going to take that, right? So it will remain deoxygenated. So even pulmonary embolism can cause hypoxia. So these are the common causes. Then we have type 2 respiratory failure. Type 2 respiratory failure. The type 2 respiratory failure is also called as hypercarbic respiratory failure or hypercapnic respiratory failure. It is also called as hypercarbic or hypercapnic respiratory failure. Why is it called so? Because here the problem is in carbon dioxide clearance. Patients are not able to exhale the carbon dioxide out. So here they have failure of carbon dioxide clearance, failure of CO2 clearance. Now I want you to remember one important point here. Hi Prajwal and hi Ayush. Ayush, we are trying to keep only the key points, brief points in this. So just go through these notes once or twice and hopefully you should be able to remember to get 70% marks for each question. Like if it is a 10-mark question, to get 6.5 to 7, you don't have to remember all the points that I'm mentioning. If you're able to replicate even 60-70% of this, mainly the headings, you will get 6.5 to 7 marks for 10, which is a good number in a medical school, right? So in type 2 respiratory failure, it is impairment of carbon dioxide clearance. Okay. Now to remember this, I will make a statement. You don't have to write the statement, but remember carbon dioxide clearance is proportionate to respiratory rate. Is proportionate to respiratory rate. Higher the respiratory rate, more carbon dioxide gets cleared. Lower the respiratory rate, less carbon dioxide gets cleared. So now tell me in what conditions the respiratory rate will be slow. In those conditions, we will have impairment in carbon dioxide clearance. So when it comes to the causes for the type 2 respiratory failure, one of the cause you should mention is drugs. And in the drugs, I want you to mention opioids, benzodiazepines. Now, why these drugs are going to cause carbon dioxide retention and why anesthetists are worried about administering these drugs? The simple reason is these drugs cause respiratory depression. So they slow down the respiratory rate and carbon dioxide clearance is proportionate to respiratory rate. Okay. But what is more common than these? The most common cause for type 2 respiratory failure is COPD. Remember yesterday we have discussed about COPD. In COPD what happens? We are able to take the air in, especially in emphysema variant, but we have difficulty to exhale the air out. We wash out the carbon dioxide by exhalation. If I'm not able to do proper exhalation, carbon dioxide will be retained in my blood itself, right? So these are the two main causes for the type 2 respiratory failure. Now the question is, I understood, okay, in one oxygenation is the problem, in another person carbon dioxide clearance is the problem. But how will I make a diagnosis? Approach to respiratory failure. Can I confidently diagnose a person having respiratory failure based on the SpO2, that pulse oximetry? No. Pulse oximetry can be used for screening purpose, but it is not very sensitive, neither specific. There are a lot of factors that influence even the device quality. So the investigation of choice, if you are suspecting that someone is not able to oxygenate himself well or not able to clear the carbon dioxide, then it is going to be ABG, arterial blood gas analysis. ABG analysis is the investigation of choice. Now, how I will interpret the ABG to decide whether patient is having type 1 respiratory failure or type 2 respiratory failure. So remember here, there is an approach. So once you have a ABG, what you should see in the ABG, first thing you should see is the partial pressure of carbon dioxide. If the partial pressure of carbon dioxide is increased, what does that mean? Remember, normal partial pressure of carbon dioxide is 35 to 45 millimeters of mercury, that all of you know for your ABG analysis. And normal partial pressure of oxygen is 80 to 100 millimeters of mercury, that all of you know. So if partial pressure of carbon dioxide is increased, it is clearly type 2 respiratory failure. But if the partial pressure of carbon dioxide is not increased, means it is either normal or maybe even decreased. normal or decreased, then I can say this is not type 2. That does not mean patient is having type 1. Patient may be normal also, right? So what I should do now next is to look at the partial pressure of oxygen. Partial pressure of oxygen. If the partial pressure of oxygen is low, if that is decreased, then you can make a diagnosis of type 1 respiratory failure. And if that is also normal, then there is no respiratory failure. No respiratory failure. Just to make you remember this algorithm, I will just take a mathematical example just to give a little bit of work to our brain so that we are able to replicate this algorithm in the examination hall. Okay, so let us say I have a patient with suspected respiratory failure whose pH on the ABG is 7.2, partial pressure of oxygen is 82 millimeters of mercury, and partial pressure of carbon dioxide is 70 millimeters of mercury. This is one example. I have one more example where pH is, let us say, 7.34, partial pressure of oxygen, let us say it is 86 millimeters of mercury, and partial pressure of carbon dioxide is 40 millimeters of mercury. Now let us try to apply these principles. Let us take the first example. What I should see first, pH is not relevant here as long as I am not making a diagnosis of acid-base disorder. For a respiratory failure, only two values are important, carbon dioxide and oxygen. First thing that I should see is carbon dioxide. So I see the carbon dioxide, right? It is increased. Now it doesn't matter what is happening with oxygen. Even if I change the oxygen value here and let us say I write it as 40 millimeters of mercury, still what will be the diagnosis? Because the pH, partial pressure of carbon dioxide is elevated, according to my algorithm, it will become type 2 respiratory failure. Simple. Next example. In the next example, partial pressure of carbon dioxide appears to be normal. 35 to 45 is normal. So when it is normal, type 2 is ruled out. It may be type 1. So next what I should see? Oxygen. If oxygen is low, then it is type 1. If oxygen appears to be normal, then it is normal. So here oxygen appears to be normal. So that means this patient does not have respiratory failure. This is going to be our approach for the interpretation of ABG. So whenever they ask you a question on the respiratory failure, define it as impaired oxygenation or impaired carbon dioxide clearance. Impaired oxygenation is type 1, impaired carbon dioxide is type 2. How to make a diagnosis? Write down this algorithm. Okay, so that is about the classification of respiratory failure into type 1 and type 2. Now the question is, how do I manage? How do I manage type 1 respiratory failure and type 2 respiratory failure? So management of type 1 respiratory failure. What is the main problem here? Oxygen, right? Patient's oxygen level is poor. So what should I do? I should be giving, first line management will be to administer oxygen through face mask or the nasal devices. Now, if that doesn't work, as a second line, I can think of NIV. What is NIV? Non-invasive ventilation, like the BiPAP, CPAP, those can be used. If that also doesn't work, what is my third line approach? I have to go for the mechanical ventilation. I started giving oxygen, not sufficient, blood oxygen levels not improving. Then I will put the patient on non-invasive ventilation without intubation. Not helping, then I have to intubate and connect him to a mechanical ventilator, right? You can call it as invasive mechanical ventilation or IM. Now, can I do something if this also doesn't help? Means I'm giving the oxygen through the ventilator, but still blood oxygen level is not improving. It generally doesn't improve when the exchange membrane is. I'm giving the oxygen, but lungs are not allowing the oxygen to diffuse into the blood because lungs are damaged. In that case, I have to bypass the lungs and put the oxygen directly into blood. That will be my fourth line management. And what do we call it when we put oxygen directly into blood? We will call it as ECMO. ECMO stands for extracorporeal. Extra means outside. Corpus means body, right? extracorporeal membrane oxygenation. Means instead of using the lung for putting the oxygen into the body, we are using an external device to put the oxygen directly into the blood. We will call it as ECMO. This is my management of type 1 respiratory failure. Now, how do I manage type 2 respiratory failure? What is the main problem in type 2 respiratory failure? These people are not able to clear the carbon dioxide, right? If I give oxygen to them, will it help them? Of course not. Their main problem is not oxygenation of blood, carbon dioxide clearance. And where do we do carbon dioxide clearance? During inspiration or expiration? Of course, expiration. So these patients need support for expiration. And how can I bring carbon dioxide that is there in the alveoli out? Yesterday I told you a rule, right? Fluid and air moves from high pressure to low pressure zone. So if carbon dioxide that is there in my blood, it has to come to the lungs, and from the lungs it has to go to the environment, then the pressures inside the lungs should be elevated so that the carbon dioxide leaves and comes to the low pressure area in the external environment. So how can I do that? By non-invasive ventilation or mechanical ventilator. There is no role of oxygen for the type 2 respiratory failure. So the first line management will be non-invasive ventilation. So there are two types of non-invasive ventilation, BiPAP and CPAP. PAP means, you can write it in the exam as preferred is BiPAP. What PAP stands for? Positive airway pressure. Means inside the airway we are trying to create positive pressure so that the carbon dioxide leaves the airway from higher pressure zone to the external environment, which is at lower pressure zone. Okay. Now that machine that I can use to create positive pressure inside the airway, I can have the same level of positive pressure created throughout inspiration and expiration. In that case, we will call it as continuous positive airway pressure or CPAP. Or I can have two settings. One level of positive airway pressure for inspiration, one level of positive airway pressure for expiration. Now these patients need help for expiration, so I don't need to give them too much of pressures during inspiration. So I want that flexibility as a doctor to be able to give higher pressures for expiration and not much support for the inspiration. That comes from bi-level positive airway pressure. So that will be the preferred choice. And the second line management for the type 2 respiratory failure will be mechanical ventilation. Mechanical ventilation. So by default, whatever is a respiratory failure, ultimately they will end up on ventilator. Okay. If we have written this much, if it is a 5-mark question, this is more than adequate. The definition, causes for type 1 and type 2, and the concept, algorithm for the diagnosis of respiratory failure, how to make a diagnosis of respiratory failure based on the ABG into type 1 and type 2, and then management if you have listed first line and second line. But if it is a 10-mark question, शायद आपको थोड़ा सा खींचना पड़ेगा. How do I spread it? Two more extra point. Miscellaneous forms of respiratory failure. Miscellaneous types of respiratory failure. So there are two more additional types. One of them we will call it as type 3 respiratory failure, and another one we will call it as type 4 respiratory failure. You don't have to elaborate the underlying principles and all, just दो line लिखना है आपको, just 2 points. Type 3 respiratory failure refers to any type of respiratory failure. Means I am saying type, it can be type 1 or type 2 occurring in patients in peri or post-operative period. Post-operative period. And it is due to, why that happens, right? It is due to lung atelectasis. The examiner is looking for this word, lung atelectasis. Now, why this is important, you may ask me, and why examiner is looking for this word, right? Two words to write here. Peri or post-operative period means whether it is hypercapnic respiratory failure type 2 or hypoxic type 1 respiratory failure. If it happens in a patient on OT table or soon after OT table, mostly because of collapse of the lung, we will call it as type 3. Now, why this happens? Especially when abdominal surgeries are done, diaphragm gets pushed up, it makes the lungs to collapse. The collapsed lungs do not participate in the gas exchange. So that's why your oxygen levels may be low. Your carbon dioxide levels may also get elevated. Now for these patients, if I give them oxygen, you may be able to achieve a better blood oxygen levels, but the collapsed lung will not open up. How can we open a collapsed balloon? By blowing air into it. So these patients need forceful blowing air into the collapsed alveoli to open them up. So that is why their management is not mainly oxygen or other steps. The management will primarily focus on incentive spirometry. Now, what do I mean by that? The patient will be asked to breathe into a box. Forcefully, they are asked to breathe into a box. So when they try to forcefully breathe into a box, they increase the pressure inside the airway, and that pressure will be distributed to the alveoli, right? Let us say that this is trachea, bronchi, right? Ultimately, I have an alveoli which is collapsed, and the patient is asked to breathe into a box. When the patient tries to breathe into a box, the box is closed, so pressure starts building up in the blocks. The pressure starts building up in the trachea, bronchial tree. The pressure starts getting directed to the alveoli and makes it open up. Atelectasis is collapse, Rajvan. Atelectasis word is used for collapse, not dilatation. So when a lung is collapsed because of pressure, by increasing the pressure inside the alveoli, we can make it open up, and that can be done by this incentive spirometry. If you are doing some ward postings, you might have seen a lot of patients will be having one small box with a tube and 3 colored balls. That is incentive spirometer. So when we ask them to blow air into it, air does not escape that box because it's a closed circuit. So pressure inside the box increases. Once the pressure inside the box increases, patient's oral cavity, throat, trachea, bronchial tree, pressure will be directed to collapsed alveoli and they will open up. Okay. Ectasia, you can count it as dilatation. Again, ectasia is a term used for ectasis is more ideal word, like bronchiectasis, dilatation of bronchi. Okay, so then we also have type 4 respiratory failure, which refers to any type of respiratory failure. Any type of respiratory failure means type 1 or type 2 occurring in patients with shock. So the word to write here is the shock. This is what examiner will be looking for. You know what is shock, right? Shock means tissue hypoperfusion or hypotension. Now, why we have to create this one more category? Because the management is going to be different. Let us say I have a patient who is having BP of, let us say, 60/40, okay, and he is also having respiratory failure. His partial pressure of oxygen is, let us say, 40 millimeters of mercury. Now, what is happening to the cardiac output in this patient? His BP is low, means cardiac output is also low. Heart is able to pump less blood. That's why BP is low. In such a case, if the oxygen level is low, what our respiratory system will try to do, means our lungs will try to increase the respiratory rate, right? We will recruit accessory muscles of respiration, sternocleidomastoid, LNA, all of that. We will start putting a lot of effort to breathe to get this oxygen corrected. But in the process, what happens? Most of the blood coming out from the heart is taken up by the respiratory muscles. So less and less blood is going to kidney, liver and brain, because majority of the blood is going to respiratory muscles. What is the consequence of this? Slowly kidneys will start failing because they are not getting sufficient blood supply. Slowly liver will start becoming dysfunctional. Slowly brain will start becoming dysfunctional. Patient will become unconscious. What we call this in clinical terms, we will call it as multi-organ failure. So it started with only one organ dysfunctional, and eventually other organs started failing because the cardiac output that is coming out from the heart is all going to respiratory muscles to keep the oxygen levels. So in such cases, the better management, if I give oxygen, I'm not solving the problem because oxygen may not improve sufficiently, cardiac output may not improve sufficiently, and still the other organs will continue to fail. So best solution is that divert this cardiac output back to the deserving organs, that is our kidneys, right, and the brain. How do I divert the cardiac output to the deserving organs? By reducing the effort put by the respiratory muscles. How can I reduce the effort put by the respiratory muscles? Simple, take charge of the respiration. Let respiratory muscles not do respiration. Give them rest. So they don't, if they are at rest, they don't need blood supply. or they don't need large amount of blood supply. So whatever cardiac output your heart is able to generate will all go to brain, kidney, liver, and other vital organs, right? So that is why the management of type 4 respiratory failure is directly putting them on ventilator so that respiratory muscles don't need to work. Mechanical ventilator. Don't waste time giving them oxygen. Don't waste time trying NIV. Put them on ventilator. The need of blood supply of the respiratory muscles will come down. All that blood will go to other organs and your other organs are stable. So mainly for these two reasons, like here we should be treating them with incentive spirometry, even if it is type 1, type 2. Even if it is type 1, type 2, in the setting of a patient with shock, we should be treating them with mechanical ventilator. So these are two additional miscellaneous types. Okay. Biotech physio के लिए already physio sir ने फर्रे कर दिया है. You can definitely go through that. So this is one more important question from the respiratory system, apart from the questions that we have discussed on asthma, COPD, and other topics. I want you to also spend some time on remembering this. Okay. Next, we will now move to the cardiology. So in cardiology today, we will be addressing 4 important topics and all the questions that can be asked from it. One is acute coronary syndrome, that is your myocardial infarction. Second one is hypertension. Third is infective endocarditis, and fourth is heart failure. Right. So we'll start with the acute coronary syndrome. What kind of question can be asked? They will ask you to define what is acute coronary syndrome. Then they will ask you to explain about the clinical features and management of acute coronary syndrome. So when this question is asked for 10 marks, the distribution of marks will be definition will generally carry 2 marks or 1 mark. The clinical features will carry around 2 marks and the management will carry around 6 marks. So within that management, you should be writing about the classification of acute coronary syndrome into unstable angina, non-ST elevation MI and ST elevation MI. You should be talking about diagnosis, including the role of biomarkers, that is troponin, CKMB and all. And then you should be talking about management. And in management, you should be talking specifically about how do you manage unstable angina, NSTEMI and STEMI under different headings. So this will give you 6 marks. Okay, so we'll follow the same approach here. We will begin with the definition. Okay, what is acute coronary syndrome? If someone presents with chest pain, does it mean he has MI? No, right? There are several non-cardiac causes also for chest. So chest pain is not equal to acute coronary syndrome. Okay. Now, if I say that, okay, I have a grandfather at home who gets chest pain after walking 100 meters, but after taking rest within few minutes, the chest pain disappears. Does he have acute coronary syndrome? No, right? So let us understand what is acute coronary syndrome. Acute coronary syndrome is not one clinical entity, but it's a group of clinical conditions, a spectrum of clinical conditions which are caused by acute onset myocardial ischemia or infarction. One of them, it need not be like MI should be there. At the same time, very, very important point here is that it should be acute onset. The grandfather story that I told you, every time he goes 100 meters walk, he will have chest pain. That means it's not an acute onset myocardial ischemia, right? He's having chronic ischemia. Every time he walks, he gets. So that is not acute coronary syndrome, right? Acute onset myocardial ischemia or infarction leading to certain clinical conditions. Those clinical conditions collectively, we will call it as acute coronary syndrome. So these acute coronary syndromes include 3 entities. The most dangerous one is ST elevation MI. The second one is non-ST elevation MI. And the third one is unstable angina. Unstable angina. Okay. I will just take 3 or 4 minutes for you to understand the concept behind this, because without the concept, we may not be able to remember and replicate in the exam. Okay. So what is this unstable angina? What is NSTEMI? What is STEMI? The concept wise think that this is the heart we are talking about. Let us say this is left ventricle. And let me say it gets blood supply from one of the coronary arteries. Okay. So as time progresses with our lifestyle and all, we build up some atheromatous plaques in the coronary arteries. So because of that, the blood flow gets reduced to the myocardium. Now, I am 43, 44. At this age, definitely I will have some degree of atheromatous plaques in my coronaries. I will have reduction in the blood flow to my myocardium. Does it mean I have ischemic heart disease right now? The answer is no. So when do you say that particular person has ischemic heart disease or ischemia of the myocardium? So for that, we need to remember that we have two levels of oxygen demand by the myocardium. One at rest. Now I'm at rest. I'm just talking to you, some minimal work, but not extensive work. So there is a rest demand of the myocardium, right? As long as that demand is met, I will not have chest pain at the rest. Now from here, suddenly I get up and start running. My myocardium starts working more, so its demand increases. So I have an exertional demand of oxygen, means that level of demand. If that level of demand is also met, even if the coronary is blocked, that level of demand is also met, then I will not have any chest pain even on doing exercise. And that's my story, right? I right now at rest, I don't have chest pain. I definitely work out in the gym, I run, and I don't get chest pain. So my rest demand as well as exertional demand of oxygen by the myocardium is met by my coronaries, even if they have 20-30% blocks. But once I'm not able to meet my exertional demand, rest demand is met, but exertional demand is not met, then after exertion, I start getting the chest pain. That state we call it a stable angina. So there we clearly know that only on exercise or physical activity I get the chest pain, not at the rest. That is stable angina. But once I start getting, like as the time progresses and block becomes larger, then even the amount of blood that my resting heart needs, I may not be able to get. In that case, the chest pain will start appearing at rest. When we have chest pain at rest, we will call it as unstable angina. Unstable angina. Okay. At this point of time, my heart is not getting sufficient blood supply even at rest. But it is still not dead, no infarction, only ischemia. But with passage of time, slowly the myocardium starts dying. The myocardium starts dying. The distal most myocardium starts dying. So once the myocardium dies, we call it as infarction. If small amount of myocardium dies, it will not show up on the X-ray as the ST elevation. Myocardium is dead, so MI is there. But I can't get it on the ECG as ST elevation because only small amount of myocardium is dead. That stage we call it as NSTEMI. But if I do not treat now, the more and more myocardium will start dying and eventually entire thickness of the myocardium is dead. We call it as transmural infarction. Then it will show as ST elevation on the ECG. So it is just a spectrum of the same condition, right? We all started with small amount of atheromatous plaque. Initially, be it rest or exertion, no compromise on the supply of the demand. So no symptoms. Then eventually what happens? Exertion, we are not able to meet the demand. We will start having the chest pain. We will call it as stable angina. But rest ke time pe, no symptoms. But if I don't address it at that point of time, somewhere down the line, the demand of rest itself is not met. I will have a rest pain. We will call it as unstable angina. If I don't address it here, then some part of myocardium will start dying. Minimal myocardial death, no ECG changes, we'll call it as NSTEMI. I don't address it here, then whole thickness of the myocardium will be dead, and then ST elevation will be evident on the ECG, then we will call it as STEMI. So all these three, see, the stable angina is not an acute coronary syndrome. Stable angina is a chronic coronary syndrome because it's a chronic ischemia. Every time I do exertion, the pain will come, not at rest. But every time it comes at rest, we are here. In no time we will reach here. In no time we will reach here. So that's why all these three are considered as medical emergencies or acute. That's why we call it as acute coronary syndrome, right? So conceptually, what is it? Unstable angina means ischemia at rest. In unstable angina, there is no infarction. No infarction. In NSTEMI, there is infarction now. Okay, where is the infarction? Very small infarction, which is more towards the distal part, means towards the endocardium. So we will call it as subendocardial ischemia. We will call it as subendocardial infarction. Subendocardial infarction. And in NSTEMI, entire thickness of the myocardium is infarcted. We will call it as transmural infarction. So which is a major emergency here? Of course, whole thickness being infarcted is a major emergency. Transmural infarction is a major emergency. But all these three are acute coronary syndrome. Now the question is how this patient will present to us. the patient will present with chest pain. He will present with chest pain, which is acute in onset, acute onset chest pain. Now, there are n number of causes for chest pain. Examiners expect you to write at least 2 to 3 points, which will help you to figure out that this patient is having chest pain because of myocardial ischemia. What are those? One, location. Location wise, it is retrosternal, just behind the sternum. Retrosternal chest pain, which is squeezing type, not sharp or penetrating type. It is squeezing type. It may be referred to shoulders, right, neck, jaw, or epigastrium. It can be referred anywhere. Don't think that it will be only referred to left arm. It can be referred anywhere, right? Shoulders, neck, jaw, as well as epigastrium. Many a times, patient presenting with epigastric discomfort may be a case of MI and not gastritis. Okay. Now, this chest pain, when do I suspect that patient is having acute coronary syndrome and it is not stable angina? So we'll call it as unstable angina when, right? So this chest pain is collectively called as angina. It will be called as unstable angina if, first point, angina started at rest. If chest pain started at rest, that means the rest demand is not met, right? Clearly, it is not stable angina. Stable angina should not have chest pain at rest, angina at rest, or angina, even if started by exertion but not relieved by rest or by taking nitrates, not relieved by rest or nitrates within 5 to 10 minutes, then we will call it as unstable angina, right? Now, the point you have to write here is any patient presenting with unstable angina is equal to acute coronary syndrome. Anyone who presents saying, sir, I was watching TV, suddenly I got retrosternal chest pain, it is unstable angina. It is acute coronary syndrome. Any patient who says, sir, I was walking, I got chest pain, I took rest, it's already 15 minutes, still chest pain is there, it is unstable angina, it is acute coronary syndrome, right? This statement will please the examiner and it will make him give 1 mark. That means you have understood the concept. Prajwal, if the breathing triggers the chest pain, it is unlikely to be cardiac in origin. It is most likely musculoskeletal, or it will be from the pleura. So either you have pleuritis or the pain is coming from your intercostal muscles or other chest wall muscles. That's it. Okay. Now, apart from this, if you can sketch this image where a person is holding his clenched fist on the chest, it will give you additional half, because there is a name given to this observation. Most of the patients who come to the emergency room with the angina, they generally hold their clenched fist, sometimes open palm on the sternum, and they keep doing this. Sorry, it hurts badly here. So this observation or this finding that they are holding their palm or clenched fist on the chest is called as Levine sign. Levine sign. So if you can draw this small sketch, it's good. It's an additional point for you for the exam. What is Levine sign? Patient holding clenched fist on the chest is called as Levine sign. Okay, so now we have described the chest pain that acute coronary syndrome patients will present with. Where is the location? What is the nature? Where it gets referred to? What is Levine sign? And how do we interpret the chest pain as unstable angina? Now, anyone presenting with unstable angina is acute coronary syndrome, but how will I know whether he is having just the simple unstable angina? In unstable angina, there is no infarction, not a major medical emergency. It is, but not major. On the other hand, STEMI is a major medical emergency. So how do I differentiate whether it is just unstable angina or whether he is actually having an MI? So clinically, I can only recognize that it is unstable angina. It started at rest or not relieved by rest or nitrates. Now to differentiate whether it is just unstable angina or infarction is there, I have to begin by investigating. So any patient presenting with acute coronary syndrome, how a patient of acute coronary syndrome presents? He presents with unstable angina. Once someone presents with unstable angina, means angina at rest or angina not relieved by nitrates or rest. First thing I would do is ECG. ECG. And when we do ECG, I will be looking for ST elevation. So if it shows the classical ST elevation, if typical ST elevation is present, then the diagnosis is straightforward. We are dealing with a case of ST elevation. But if ECG does not show ST elevation, that does not rule out myocardial infarction, right? If ECG shows no ST elevation, then those patients will be called as having non-ST elevation acute coronary syndrome, right? It can either be, what are our pending things? It can be NSTEMI or just unstable angina. Now the question is, how will I differentiate between these two? See, what is the main difference? Look at this. I've given you the concept. In NSTEMI, there is infarction. In unstable angina, there is no infarction. So how do I differentiate? Whenever myocardium dies, it releases proteins within the myocardial cells into blood. What are those? Troponin, CKMB, right? Ischemia modified albumin. These intracellular cardiac proteins will be released into blood whenever myocardium is infarcted or damaged. So in case of unstable angina, because there is no infarction or damage, these markers will not be released into blood. On the other hand, in the MI cases, whether it is STEMI or NSTEMI, these markers will be released into blood. For STEMI, I don't need to rely on the markers. I am diagnosing it with the ECG. But here I have to rely on the markers. So if the markers are positive, that means infarction is there, then it is NSTEMI. If markers are negative, no infarction, then we will call it as unstable angina. So next step here will be to go for those markers. What markers are usually preferred? The most commonly performed marker is troponins, cardiac troponins. So if the troponins are elevated or positive, that means there is infarction. So in that case, our diagnosis becomes non-ST elevation MI. And if the troponins are negative or not elevated, if they are not elevated, then there is no infarction. If there is no infarction, then we will call it as just unstable angina. So this is our approach to the diagnosis of acute coronary syndrome. So under acute coronary syndromes, we have two things. Unstable angina means critical ischemia, rest, exertion demand both not met. So pain is there at rest itself, but no myocardial death has happened yet. You don't treat now, after some time, subendocardial infarction will start happening. In that case, we will start calling it as NSTEMI. So once the subendocardial infarction happens, troponins will become positive. If I treat now, good. If I don't treat, after some time, whole thickness of the myocardium will be dead. That is what is called as transmural infarction. That time ST elevation will be shown, and then we will call it as STEMI. Okay. So now that we have learned the diagnosis, we will just put a small point or note on the role of biomarkers in MI. Role of biomarkers, because this can be a 2-mark question. Biomarkers in MI. Why do we do biomarkers? Abhishek Singh, I will connect with you after the class. Don't worry about it. You will definitely sail through. We all felt medical syllabus is vast, but we have sailed through. You will also sail through. Okay. So first thing you have to write is the earliest marker to rise. Earliest marker to rise. Second is sequence of rise. Sequence of rise of these biomarkers. The earliest marker to rise is ischemia modified albumin. Ischemia modified albumin. In some of your older textbooks, they mention myoglobin, which is not currently correct. Once upon a time, it used to be. Now we have identified so many more molecules which rise even before the myoglobin. So right now it is the IMA or ischemia modified albumin. What is the sequence of rise? The first one to rise is ischemia modified albumin. Followed by that, we have heart type fatty acid binding protein. Heart type fatty acid binding protein. Next one is your CKMB, and almost same time you have roughly troponins. CKMB and troponins. So this is the most important sequence that I want you to remember. Okay, I forgot to mention, even before the CKMB, though we do not investigate or do this test on a routine basis, biochemistry people tend to ask this question, so you should remember myoglobin and then CKMB. How do I remember this sequence? There's a simple mnemonic. I have my cat. You know, like I definitely have a small cat at home. So you can remember the mnemonic I have. I for ischemia modified albumin. Second is heart type fatty acid binding protein. My for myoglobin. Cat. C and T. Right? I have my cat. C for CKMB and T for troponin. That is the sequence of rise of biomarkers after onset of infarction. Okay. Now the third thing you should write is the biomarkers useful for diagnosis of reinfarction, because after one MI, it doesn't mean that MI will not happen again. So for diagnosis of reinfarction, which markers are used, right? First one is serial rise in troponins, and second one is CKMB. You don't have to elaborate on the biomarkers until and unless specifically asked by the examiner, right? Write the role of biomarkers in the diagnosis of myocardial infarction, or it is a 2-mark question asking you to write about biomarkers in MI. Otherwise, this algorithm is more than enough. As long as you're able to write it, you are sailing through the marks. Okay, so now we know how to make a diagnosis of acute coronary syndrome. We'll talk about the management. The management of acute coronary syndrome, I want you to divide into 2 sections. In the first section, the general management which applies to all cases, whether it is unstable angina, NSTEMI or STEMI, all the cases of acute coronary syndrome, this applies. And then we should write about the specific management of unstable angina, NSTEMI and STEMI. So we'll first start with the general management. What is the problem in acute coronary syndrome? You have a myocardium which is suffering through the ischemia, right? One of your blood vessel is blocked. And because of that, some part of your myocardium is not getting blood supply. In unstable angina, it is not dead. In the NSTEMI, subendocardial infarction, in STEMI, transmural infarction. But in all the 3 circumstances, there is critical ischemia and the blood flow needs to be re-established. Okay. How do we do that? So number 1, we have to remember that there is a clot which may propagate, become bigger and cause more problems. If it is unstable angina, it may become NSTEMI, and STEMI may become STEMI. So I have to halt the clot propagation, right? So first thing that I will do to achieve that is antiplatelets. So any patient of acute coronary syndrome should be given antiplatelets. How many antiplatelets? Dual agents, and we should be giving loading dose. You should mention the loading dose of aspirin, and yes, statins also we will be giving aspirin and clopidogrel. Aspirin we will give 325 milligrams and clopidogrel we will give 300 milligrams. Okay. Then second thing, we will give statins because atheromatous plaque formation will be halted by giving statins. Third, we will administer these patients beta blockers. Now, why am I giving beta blockers here? Remember, why this myocardium is dying? It is dying because it is not getting as much blood supply as it wants. Right? Let us say it wants 100 ml of blood supply and it is only getting 30. So sufficient demand is not met, it is dying. So you can say there is demand and supply mismatch. So if I have to get this balance right, I have to decrease the demand and increase the supply. So I'm taking steps to increase the supply. I have to also take the steps to decrease the demand. So how beta blockers will help? Beta blockers will decrease the heart rate. If heart is beating less, it needs less blood supply, right? So that helps us to decrease the myocardial oxygen demand. So beta blockers cause decrease in heart rate. By decreasing the heart rate, they cause decrease in myocardial oxygen demand. Myocardial oxygen demand. Not only just that, beta blockers cause vasodilatation, and by causing vasodilatation, they can also increase the coronary blood flow. Coronary flow. So they are helping you to get the balance. Decrease demand, increase supply. Okay. Then next is we should also give them adequate pain management, right? So pain control is very, very important in a case of MI. And remember, the drug of choice for pain control is IV morphine. Why morphine? Why not NSAIDs? The simple reason is morphine has an added advantage. What is it? Morphine causes parasympathetic stimulation. And what is the benefit of that? Parasympathetic stimulation will suppress the cardiac activity or sympathetic activity and reduce the heart rate. So morphine not only takes care of pain, right? It will decrease pain and it will increase parasympathetic nervous system activity, and by doing so, that will result in decreased heart rate, and decreased heart rate means decreased myocardial oxygen demand, which is beneficial when you're having the critical situation, right? So that's why for pain control we use morphine, not NSAIDs. Okay, what else I can give? The fifth thing that I would end up giving is sublingual nitrates. How nitrates are going to help me? Nitrates cause vasodilatation. By causing vasodilatation, they can increase coronary blood flow. So these are the steps that are generally taken for all the patients of acute coronary syndrome. Rahim Rashid, very good, very good. Today, generally we do not use oxygen because oxygen alone is not going to solve the patient's problem. As long as blood oxygen level is fair enough, the goal is to decrease the demand and increase the blood supply, not just the oxygen. But if patient is hypoxic, we can give oxygen. So these are the general management. Now coming to the specific management, this is what examiner is more interested in. They will not look at the general management. These general management related questions examiners are looking at in the pharmacology papers, not in medicine. In medicine, we are looking at whether you can write the algorithm for specific management of STEMI. Okay, so in STEMI, the whole myocardium thickness is dead. Now, if I do not open this blood vessel, larger areas will become dead, which is more critical. I don't want that to happen. So I want to open this blood vessel as soon as possible. So how we can open? The definitive treatment of STEMI is revascularization. Now, what do I mean by that? Open the blocked blood vessel. It is called as revascularization. Revascularization. It can be achieved by two methods. One is thrombolysis. The second one is percutaneous intervention. Is also called as angioplasty. Okay. So now I have two choices to open the blocked blood vessel. Which one would you prefer? So I am going to write one statement here. In terms of achieving the revascularization or opening of the blocked blood vessels, PCI is superior. PCI is superior to thrombolysis. Of course, Rohina, absolutely right. So PCI is superior to thrombolysis. That's why PCI should be preferred. The success rates of thrombolysis in India is less than 50%, while PCI is close to 100%. So what we should prefer? PCI is preferred, but in not all circumstances PCI is possible, right? In India, in remote tribal areas, there's no cath lab, there's no cardiologist. So how will I do PCI? So in such cases, we can go for thrombolysis. So we have to write an algorithm for the approach to STEMI. How will I decide whether I should do thrombolysis or whether I should go for the PCI? So remember, first thing that I will see is whether the patient is seen first at, whether I have seen him in a hospital where PCI is possible. PCI capable center. Means I'm in a big corporate hospital, cardiologist is there, cath lab is there, angioplasty is possible. And I've got a patient here. What should I do? Thrombolysis or angioplasty? Cardiologist is there, cath lab is there. So of course I should do angioplasty, right? So treatment will be PCI. Now within how many minutes of patient coming to me, I should do the PCI. So remember, PCI should be done within 90 minutes of patient coming to the emergency room. So we call it as door, patient coming to the emergency room door, that is door to balloon time. What is balloon here? For angioplasty, we use a small wire on which there will be a balloon. Like if this is a blood vessel, I will pass a wire into this. There is a block here, let us say, and this wire will have a balloon at the end of it, which I will inflate to dilate the coronary artery. So balloon of this angioplasty catheter entering into patient's coronary artery, that time is called as door to balloon time. Patient coming to your emergency room door and the angioplasty balloon entering his artery. Total time taken is door to balloon time. It should be less than 90 minutes. We should do that within 90 minutes. In India, in corporate hospital, definitely we are able to achieve that comfortably. Not a big deal at all. We have plenty of cardiologists available. We have plenty of cath labs available. But in the peripheries is where we have the challenge. So if patient lands up in a PCI incapable hospital, PCI incapable hospital, either cardiologist is not there or cath lab is not there or doctor itself is not there. In such cases, what should I do? Should I refer for the angioplasty or do the thrombolysis? I already know angioplasty is better than thrombolysis. Ideally, we should be doing best for the patient, not something which is inferior. But I don't have the cap. What I should do? So here the decision is dependent on if I refer, how much time it will take for the patient to reach a cath lab. If he is able to reach in a reasonable time, why should I do thrombolysis? I will refer him and let him get the best treatment done. But even after referral, he is likely to reach late to the hospital where angioplasty is possible, then I will do thrombolysis, right? So then there is a concept called as expected FMC. FMC here stands for first medical contact. Like, okay, now I am in a remote tribal area, I saw this patient. So he came in contact with me, that is the first point, first medical contact. I am the first medical contact. So from first medical contact to, if I refer and get the angioplasty done, how much time it will take for the balloon to go into patient's coronary artery? FMC to balloon time. If it is more than 120 minutes, if it is more than 120 minutes, then there is no point in referring, because by that time major damage to the myocardium will be done. But if it is less than 120 minutes, like if I refer from here and within 120 minutes angioplasty can be done, then I should refer this patient for PCI. Refer for PCI. Whatever aspirin and all we have given, we will give and refer. But if it is more than 120 minutes, we will do thrombolysis. And as I already know that thrombolysis will be successful only in less than 50% patients. So even if I give thrombolytic agents, half of them will not open their blood vessel. So after thrombolysis, I can't keep the patient in that periphery. Soon after thrombolysis, I should send him to PCI. Refer for PCI. So PCI is the main treatment for patients with STEMI. Only thing is that if it is going to take too much time to get the PCI done, we do thrombolysis and refer. Otherwise, it's always about PCI, right? I want you to memorize this algorithm and exactly how I have written it here, comment it out on the examination paper. Okay, so that's about your STEMI management. Now the NSTEMI. What is the difference between STEMI and NSTEMI? In the STEMI, why do I have the full thickness of the myocardium gone? Because remember, if this is my coronary artery, how a clot formation starts? This is my endothelium, right? Let us say this inner layer is the endothelium. Let me label it in blue color. This is the endothelium. What is it? Endothelium. So in the subendothelial space, there will be collection of the fat deposition, what we call as atheromatous plaque. So here I have the fat deposited. As the fat deposition starts increasing, it will cause a rupture of the endothelium. We will call this phenomenon as plaque rupture. So this is called as atheromatous plaque. When it ruptures, it is the plaque rupture. Once the plaque ruptures, all hell breaks out for the patient. Why? Because once the plaque ruptures, on the subendothelial side, there will be these substances called as von Willebrand factors. If you remember from pathology or hematology of medicine, von Willebrand factor. These von Willebrand factors are platelet attractants. So once there is endothelial injury because of the plaque rupture, then next things are not easy to control. So now what will happen? The platelets will come and bind. That is what we call as initial step, platelet adhesion. These platelets will send some signaling molecules like ADP, thromboxane A2 to bring more platelets. So more platelets will come and form the bigger clot. This stage we call it as platelet aggregation. Now we have a fully formed platelet plug. At this point of time, the blood flow is severely reduced and patient will start developing unstable angina. At rest only, blood supply is not sufficient. If I don't take care of it at this point of time, the next step is there will be activation of coagulation cascade and body will start making fibrin. So when some amount of fibrin is formed, the subendocardial portion starts dying and we will have subendocardial infarction. That is our NSTEMI. Little fibrin, large platelet. But if I don't address it here, after some time, this fibrin will increase. The fibrin cap will become much bigger, critically occluding the artery, and then whole of this myocardium will be dead. So if I'm seeing a patient at a stage where he is having subendocardial infarction, and I want him to not go through the STEMI, what should I do? What I can do? Rohina, absolutely right. So I do not want this fibrin mesh to propagate further, become much bigger. How can I stop the fibrin mesh from becoming bigger? Inhibit the formation of fibrin, and the drugs that are used for inhibition of the formation of fibrin are called as anticoagulants, because this fibrin formation is coagulation. So that is why in NSTEMI, first step is always to start anticoagulation. And what is the preferred anticoagulant? Of course, I want to have this anticoagulation effect as soon as possible. So I can't start warfarin. If I give warfarin today, 4 or 5 days later, it will start showing the anticoagulant efficacy, because warfarin acts by blocking vitamin K. And once I block vitamin K dependent coagulation factors 2, 7, 9, 10 will not be formed. But whatever 2, 7, 9, 10 which is already formed will be still working. Only when they are also cleared from the body, anticoagulant efficacy will come. So that is why I can't use warfarin. I want something which is quickly acting. Heparin is the best drug. And because of the convenience, low molecular weight heparin is preferred. So anticoagulation with heparin, preferably low molecular weight heparin will be given. So once I do that, right, the fibrin will not progress further. So this NSTEMI patient going to STEMI is blocked. Now I can relax a bit. Right? I can breathe, because at least whole myocardium is not going to die. Whatever that is dead, that is dead. But now this plaque I have to clear to get the better blood flow, right? But it's not going to be as emergency as this STEMI. So I can take sweet time to clear this clot, right? So first step is that. Second step is PCI. But for PCI is angioplasty, right? Put a balloon, dilate, and then put a stent. For that, I don't have to rush to do it within 90 minutes. For the STEMI, we were doing it within 90 minutes. But here, I can do it within 24 hours. You may ask, sir, is that okay? It is okay, because I have started anticoagulation and this fibrin mesh will not propagate further. So that's why it is okay. Now, in reality, do we wait for 24 hours for NSTEMI patients? No. If the cardiac center is not busy, we will do it off, just like the STEMI cases, within 15 minutes, 20 minutes, if it is possible, we will do it off. But I can take time up to 24 hours in case of NSTEMI. This is the case management of NSTEMI. In unstable angina, what do we do? In unstable angina, plaque is ruptured, platelet plug is being formed, and fibril deposition is about to start. I do not want the fibril deposition to happen. So that is why here the first step is again same, anticoagulation. But the second step, that is PCI, is done only if patient is refractory to anticoagulation. Means despite anticoagulation, patient continues to have chest pain, then only we do angioplasty for the unstable angina patient. NSTEMI, STEMI, for both of them we do angioplasty. STEMI ideally within 90 minutes. Not possible, think of getting it done within 120 minutes by referral. Not possible, then thrombolysis. In NSTEMI, anticoagulation and do angioplasty in next 24 hours. In unstable angina, you don't have to think of angioplasty first. Just start anticoagulation. If all goes well, patient pain comes down, send him home. But if the pain persists despite giving anticoagulation, then only we do angioplasty. Okay, so you have to remember this. This is the summary of the acute coronary syndrome. Now, sometimes they can ask a 2-mark question on the complications of myocardial infarction. What complications it can lead to, right? So we will list some of them. The first one is shock. Of course, your heart is not getting sufficient blood supply, it is not going to contract well. So cardiac output will come down, patients can go into shock. Okay. Second, let us say this is left ventricle. Some part of it is not getting blood supply, so this portion dies. And once this portion dies, right, rest of the myocardium is contracting, so there will be strong forces generated inside the myocardium. Those forces will push this dead portion to balloon out. We will call it as ventricular aneurysms. Ventricular aneurysms. Then the third thing, the myocardium, it's not just the myocardium is supplied by the coronaries, but also the conduction system of the heart. Like for example, SA node receives the blood supply from the right coronary artery. So if it is the right coronary artery block causing MI, SA node may also be affected, AV node may also be affected. So we can have AV blocks. We can develop first degree, second degree, or even third degree heart blocks or AV blocks. Fourth, this infarcted tissue can become a focus for forming arrhythmias. So we can develop ventricular arrhythmias. Ventricular arrhythmias. That is VT and VFib. Okay. And another immunological complication called as Dressler's syndrome. Dressler's syndrome. What is Dressler's syndrome? It refers to post-MI autoimmune pericarditis. Autoimmune pericarditis. Means when we have an MI, some part of myocardium is dead. Myocardial proteins which are not usually exposed to blood now come into blood. Body produces antibodies against them. And structurally similar proteins also exist in pericardium. So these antibodies will go and attack the pericardium, cause inflammation. Right? Post-MI autoimmune pericarditis is Dressler syndrome. Okay. What else we can have? This myocardium which is there is not participating in contraction. So the force of contraction has come down. So circulation of blood is disturbed. We may end up with heart failure. Heart failure with pulmonary edema. Okay. Another complication that we can get is development of mitral regurgitation. Many patients with MI can develop mitral regurgitation. Now, why do I develop mitral regurgitation? Remember, in the left ventricle, to prevent the mitral valves from opening in the opposite direction. See, normally this is left atrium, this is left ventricle, this is my aorta, this is where I have the mitral valve. Mitral valve. Now, to prevent this valve from opening in the opposite direction so that blood doesn't regurgitate, we want to hold the valve leaflets in position, and for that we have structures called as papillary muscles and chordae tendineae. Now, what are these muscles? Muscles means they also need blood supply. So if they don't get blood supply, the muscles will become dysfunctional. They will not be able to hold the mitral valves in position. So mitral valves will open in opposite direction and the regurgitation can happen. So mitral regurgitation due to papillary muscle infarction. Papillary muscle infarction. So these are all complications of the MI or acute coronary syndrome. We will be covering, Rohina. We will be covering. We will be covering. Okay, so that's about our acute coronary syndrome. Individual segments of the questions we have addressed. Next, we will go to one more important question, which is hypertension. Hypertension is repeatedly asked across universities as a major 10-mark question because, of course, it's the common problem of our society, right? Examiners also focus on more common diseases than rare. So, what is expected on a 10-mark question? Let me ask you to define and lay down the cutoffs for the diagnosis. 2 marks for that, 1 to 2 marks for it. Then complications of hypertension, usually 2 marks for it. The diagnostic cutoff, 1 to 2 marks for it. What BP you can make a diagnosis of hypertension. Classification of hypertension, 1 to 2 marks for it. Then either they will ask you to write a short note on the hypertensive emergencies and urgencies or the resistant hypertension, for which they tend to give 3 to 4 marks. The closing question may be write briefly about hypertensive emergency and urgency or write a short note on resistant hypertension, right? So we'll begin with this. What is hypertension? Elevated blood pressure beyond threshold for age, gender, and ethnicity. For that particular age and gender, whatever is defined as a threshold, if your BP is more than that, we will call it as hypertension. Okay. Now, how do I make a diagnosis of this hypertension? There are different criteria or cutoffs. Currently, what we are following is European Society of Hypertension 2023 guidelines. You don't have to write this in the exam, but as long as you're writing these key points that we are going to discuss now, it's more than enough to get full marks. Okay. So for diagnosis, a particular person is said to have BP when his BP is above these defined thresholds. But of course, the threshold is going to depend on the method of measuring the BP. BP can be measured in patient's home, in the hospital, or it can be measured 24 hours. Of course, when it is measured in the hospital, BP generally becomes higher, right? Because of what is called as white coat hypertension. So if I am measured in the hospital, I have to have a higher cutoff. If I am measuring at home, anxiety level is less, so it will be slightly lower, so the cutoff will be lower. But if I'm measuring for 24 hours, which is the preferred method, it will be even more lower because in the 24 hours, we also sleep. During sleep, our BP is usually lower, right? So first point I want you to mention is what is the preferred method. Preferred method is 24 hours ambulatory BP measurement. Ambulatory means moving around. Patient wears the badge or a device for recording the BP and he does his routine activities for 24 hours. He eats, sleeps, fights with his wife, goes for a walk, goes to gym, whatever he does routinely, he does. 24 hours later, we remove the device and measure the average BP. That is the preferred method because it is less influenced by external factors and it is representing of his day-to-day BP. If that is not possible, then recording home is the second preferred method because white coat hypertension is not likely to interfere. Least preferred is office BP or hospital BP. Office means hospital, not patient's office, doctor's office. That is least preferred because, why is it least preferred? Because of concern of what is called as white coat hypertension. Okay. So now my cutoffs are going to depend on which method I am following for the diagnosis. If I am following 24-hour ambulatory BP, my cutoff for diagnosis of hypertension is systolic more than or equal to 130, diastolic more than or equal to 80. It's very easy to remember. You just begin from the bottom of the table. Least expected BP is when you record it for 24 hours because it is including the average of sleep. So write it as 130, 80. Now add 5 for home BP, 135, 85. Add 5 more, which is a famous number for all of us, 140, 90 for the hospital record. So recorded in the hospital, 140, 90, recorded at home, 135, 85, 24-hour recording, 130, 80. So that completes our diagnostic cutoff, 2 marks done. Okay. Now examiners generally tend to not ask about the grading of hypertension, but if they're asking, we should also be able to grade the hypertension. Once that you have diagnosed patient as having hypertension based on this cutoff, we have to grade it as grade 1, grade 2 or grade 3. For this grading, the grading is based on office or hospital BP, not based on the 24-hour BP or not based on the home BP. It's only for initial diagnosis, just to get rid of that white coat concern. After that, for grading, we can't keep asking the patient to wear that badge regularly every month or send someone to patient's home to record BP every month. So we record it at hospital only for grading. Okay. So 140/90 is hypertension, we know, right? So 140 to 159 systolic or 90 to 99 systolic will be called as grade 1. 160 to 179 systolic and 100 to 109 diastolic will be called as grade 2. And the more than 180 or more than 110 diastolic will be called as grade 3. Again, pretty easy to remember. You don't have to remember these n numbers. Instead, simply remember it as 140 to 160, 160 to 180, more than 180. Right, 90 to 100, 100 to 110, 110 plus. So that is our 3 grades of hypertension. Once we have written about grading, then comes the classification of hypertension. How do we classify hypertension? It's basically classification of causes. So hypertension is classified into 2 broad groups. One, primary hypertension. Primary hypertension, you can also call it as essential hypertension. Essential hypertension. And the other one is secondary hypertension. So when we have an identifiable treatable cause, we will call it as secondary hypertension, right? So in secondary hypertension, identifiable cause is present. This is less common. This accounts for 10% of patients. 90% of the patients, there is no identifiable cause. That is what we call as primary hypertension. Of course, for primary hypertension, risk factors are there. You can't pinpoint one cause. But for secondary, we can pinpoint one cause. So what are the causes for secondary hypertension? The first and the most important cause for secondary hypertension is renal disease. Renal disease. Rohina Rashid, very good. Renal disease means, example, CKD. Patients with CKD are often having hypertension. Then you know that glomerulonephritis, right? Post-streptococcal glomerulonephritis, whatever forms of glomerulonephritis, they present with hypertension. Glomerulonephritis, they present with hypertension. Second, renovascular disease. Renovascular disease. Now, what do I mean by that? If the blood supply to kidney is cut off, BP increases. Why? Because to regulate the blood flow to kidney, we have a RAS that gets activated and BP increases. So like renal artery stenosis. Renal artery stenosis. Third, drugs. Many drugs are known to cause hypertension. Can you give me an example for drugs known to cause? Steroids. Right? Steroids. Then mephenteramine, sibutramine. These are all sympathomimetics, right? Sibutramine. Okay. Apart from that, we also have endocrine causes. I think Rohina had already mentioned one. Endocrine causes include diseases like Cushing syndrome, then pheochromocytoma, Conn's syndrome or hyperaldosteronism. So these are all the conditions where you can have hypertension. So these are all secondary causes. For the primary hypertension, we don't know causes. We can only mention risk factors. So what are the risk factors for the primary hypertension? Obesity, single most important risk factor, right? Obesity, sedentary lifestyle, high salt diet, right? Decreased magnesium in the diet. These are all smoking. These are all important risk factors that you can mention. Please remember, you don't have to write all the points that I'm writing here. It might seem like very vast and you may not be able to get that right, get that time. So if I'm writing 5 points, if you're able to filter out 3 out of this, it's It's more than enough. The reason I'm mentioning 5 is that so that you can carry forward 3 in the examination form. Okay. So this is about our classification. So if you're able to do this, you will get 2 marks. Give the broad approach, primary, secondary. In the secondary, at least mention 2-3 causes. Endocrine, renal diseases, drugs. One examples for them. It's more than enough. Now we know the causes. Next thing we will mention is complications. What complications hypertension can lead to? The complications will be classified into acute and chronic. So examples for chronic complications: can long-standing hypertension affect eyes? Yes. What do we call it as? Hypertensive retinopathy. Hypertensive retinopathy. Can it affect kidneys? Yes. What we call it as? Hypertensive nephropathy. And when you write hypertensive nephropathy, I want you to write one important point in the bracket. Hypertension is second most common cause for CKD. Diabetes is the most common. Diabetic nephropathy is the most common cause for chronic kidney disease. And hypertension is the second most common cause. Okay. What else hypertension can affect? Retinopathy, nephropathy. Okay. What chronically? It can also cause this heart failure. Why hypertension causes heart failure? Because of the left ventricular hypertrophy. Chronic heart failure. Okay. What acute complications I can expect? Number 1, hypertension can lead to stroke. Both the stroke can be ischemic as well as hemorrhagic. So when you're writing hemorrhagic stroke, I want you to write that the most common site of bleed, most common site of hypertensive bleed is going to be putamen, which is part of your basal ganglia, Okay. What else it can lead to? Is stroke the only complication, acute complication? No, it can also cause acute heart failure. Heart failure can be acute as well as chronic. Okay. What else it can lead to? It can also lead to acute kidney injury. It can also lead to aneurysmal dissection. Patients may develop the aortic aneurysm and aneurysms can rupture. So these are all acute complications of hypertension. If you are able to mention 2 or 3 on each side, good enough. So now what we have learned about hypertension, objective terms to remember here is the diagnostic cutoff and the grading, classification, few complications. After that, we will talk about the management of hypertension. Now, in the management of hypertension, slightly confusing. If you can remember, well and good. Otherwise, you just make a list of drugs that you are familiar with. AC inhibitors. Write down about the mechanism of action. Like AC inhibitors, they will inhibit the formation of angiotensin to thus reduce the hypertension. Beta blockers, right? Write the mechanisms. If you can remember this algorithm, well and good. What algorithm says? To prevent these complications, I have to lower the BP. I have to achieve the target BP. What is my target BP? Target BP is less than 130 by 80 millimeters of mercury. Only if I maintain the BP less than 130 by 80 millimeters of mercury, my patients will not suffer acute and long-term complications of BP. So to achieve that, I have to use drugs in the form of pharmacotherapy and also lifestyle modification. So how do I decide? So if the patient's BP is more than or equal to 150 by 95, immediately I have to start drugs. But if BP is not as high as this, right, it is on the lower side, maybe 130, 80 plus, but not as high as this, but patient has some coronary vascular disease risk factors, I will start with the pharmacotherapy. If BP is 140/90, but patient does not have any hypertension related organ damage and coronary artery disease risk, in such patients, not more than 150/90, but 140/90 plus and no risk factors, I will try lifestyle modification for 3 months. It doesn't work, then I will start with the pharmacotherapy. Okay. Now the question is, what pharmacotherapy we can prefer? Pharmacotherapy of hypertension when it is required, right? Combination of AC inhibitors or ARBs plus dihydropyridine calcium channel blockers is first line management. So we do not give single drug. It is the first line management, right? In uncontrolled cases, spironolactone, then beta blockers or other classes can be added. So at least this much you should be able to write, that the first line is combination of AC inhibitors or ARBs and dihydropyridine calcium channel blockers. Okay, this is pharmacotherapy. What is the recommended lifestyle modification? There are two recommendations or three you should mention. First, salt. Second, diet. Third, exercise, right? So first is salt restriction to less than 4 grams per day. Then 30 to 45 minutes of aerobic exercises per day for at least 5 days a week. And the third one is diet. Preferred diet is, there is something called as DASH diet. Dietary approach to stop hypertension. DASH diet is to be recommended. This is about our lifestyle modifications. You will get 2 marks for writing a little bit about pharmacotherapy and lifestyle modification. If you can remember this, well and good. Otherwise, don't bother for the prof exam. For MCQs, definitely you have to remember this algorithm, but not for the prof. Okay. So now coming to the last leg of the question, that is about hypertensive crisis. Under that, we have hypertensive urgency and emergency. So what is this hypertensive crisis? Let us say I have a patient with BP. His usual BP used to be 150/90. I have started him on medication, but suddenly it shoots, right? If there is acute rise in BP to a value more than 180/110, in that case, we will call it as hypertensive crisis. Crisis means sudden rise in the BP to 180/110 or higher. Now that sudden rise in the BP will be further classified into hypertensive urgency and emergency. Hypertensive urgency and hypertensive emergency. So what is the difference between the two? In hypertensive urgency, BP has risen above 180/110, but that rise in the BP has not resulted in any damage to the internal organs. Means there is no hypertension mediated acute retinopathy, acute heart failure, or acute stroke, no hypertension mediated organ damage. So even if BP is elevated but organs are not damaged, we will call it as urgency. But if the acute damage to organs has happened, then we will call it as emergency, right? With damage, it is emergency. Without damage, it is urgency. Okay. So what hypertension mediated organ damage we are talking about? Development of stroke, right? Acute kidney injury or myocardial infarction or heart failure. These are our acute emergencies. So if any patient with sudden rise in BP presents with stroke or bleeding in the brain, it is hypertensive emergency. Or if any patient with sudden rise in the BP presents with MI, it is hypertensive emergency. If he presents with heart failure, it is hypertensive emergency. If he presents in renal failure, it is hypertensive emergency. But if a patient with 150/90 regular BP suddenly becomes 200/110, but no organ is damaged, it is hypertensive urgency. Okay. Now, how will we manage this hypertensive crisis patient? Remember, urgency, BP needs to be lowered. I definitely don't want the BP to be more than 180/110. Because organs are not being affected, I don't have to suddenly lower the BP here. I have to take my own sweet time to bring the BP down. So in urgency, if the patient is already on antihypertensives, we have to just increase the dose. Or if he is not taking it properly, ensure that he takes it properly. And if he is not on medication, we start. Not a non-hypertensive, sudden rise in BP, we start the medication. Non-hypertensive on medication, still shoots up, we increase the dose. No need to do any admission or emergency management. But in case of emergency, where you have stroke, or acute retinopathy, or you have acute kidney injury, or you have, let us say, development of MI or heart failure. In those cases, we have to lower the BP quickly. So normalization of BP is recommended in hypertensive emergency within 24 to 48 hours. And to achieve such quick lowering of the BP, we will definitely require IV, parenteral antihypertensives. It could be nitroglycerin, nitroprusside, or IV labetalol or nicardipine. These are available in IV form. We can use them. So what is the difference in managing emergency and urgency? Emergency, no organ damage. So treat it on oral antihypertensives. Increase the dose or start. Emergency, there is organ damage. So here we need to reduce the BP quickly. Normal BP should be achieved within 24 to 48 hours. You can achieve that with IV antihypertensives. Labetalol, yes, generally labetalol is preferred, but depending on the precise organ damage, we can choose different agents. Yeah, but you can just mention the list of these agents at the level of exam. For the MCQs, we will discuss it later. So that is about our hypertensive, emergency, and urgency. Now, one more question that can be tagged to this is define refractory hypertension. Refractory hypertension, mention causes and management. Mention causes and management. Okay, so what is refractory hypertension? The definition is, okay, we will start with resistant, then we will come to refractory. Resistant hypertension, mention causes and management. So what is it? BP not controlled to target. Now what is our target BP? The target, currently accepted target, is less than 130 by 80 millimeters of mercury, despite use of optimal or fully tolerated or well tolerated dose of more than 2 antihypertensives, or you can, instead saying more than 2, you can say more than or equal to 3 antihypertensives. More than or equal to 3 antihypertensives, out of which one is a diuretic. Means we are using at least 3 drugs for the patient at ideal dose, or at least the dose that patient is able to tolerate without side effects. At that dose, we are using 3 agents. Out of that, one is a diuretic. Still, BP is not controlled. We call it as resistant hypertension. And what is refractory hypertension? Refractory hypertension refers to uncontrolled hypertension despite use of 5 agents. Hypertension despite use of 5 drugs. Then we call it as refractory. Means these 3 plus we have started 1 or 2 more, still not controlled, then it is refractory hypertension. Now what can cause it? The causes for resistant hypertension. Causes for resistant hypertension. Remember, most common cause is poor compliance. Means patient, you are giving 3 drugs, but patient is not taking. Poor compliance. In such case, you can also call it as pseudo-resistant hypertension. Pseudo-resistant hypertension means actually it is not resistant. Drugs will work, but patient is not taking. For our side, we have given 3, not controlled. Then second one is renal diseases. That is your CKD, glomerulonephritis. The third one is renal artery stenosis. Renal artery stenosis. Your renal artery is blocked or stenosed, that is causing resistant hypertension. Next one is endocrine causes. So whatever we described as secondary causes for hypertension, they all can cause resistant hypertension. So endocrine disorders include pheochromocytoma, and then we should also have Cushing syndrome, Conn's syndrome, Even growth hormone excess can also cause resistant hypertension. So these are the important ones that you need to mention. Okay. Now, how do I manage management of resistant hypertension? There should be two things here. One, treat underlying cause. That's most important, right? So if there is a pheochromocytoma, until and unless I operate it, it's not going to come under control. Treat underlying cause. Second one is, till underlying cause is sorted, we can try to control BP with the drug of choice for BP control is spironolactone. That does not mean that I will control BP with spironolactone alone. Whatever patient 3 drugs is already taking, I will add spironolactone to that. So adding spironolactone is the pharmacotherapy for resistant hypertension. Treating the underlying cause is the mainstay of treatment. So whatever they can ask from hypertension can be addressed from whatever we have discussed so far. Okay. So next up, we will go to another topic which is regularly asked, which is infective endocarditis. So usually it's a 5-mark question. Most exams it's going to be a 5-mark question. What is expected from the infective endocarditis? Mostly they will ask you to describe the causative agents for infective endocarditis, which is going to be 1 to 2 marks. Then they will ask you to write in brief about the clinical features, for which they give 2 marks, diagnosis 2 marks, and if they are asking about management, 1 mark. Mostly whole stem is not asked. Usually they will ask you clinical features and management, or clinical features and diagnosis, or diagnosis and management, or causative agents and clinical features. That's how they make it a 5-mark question. Or sometimes they combine it with rheumatic fever. So it's like write a brief note on infective endocarditis and rheumatic fever, 5 marks each. Okay. So we will first begin by defining the infective endocarditis. So what is infective endocarditis? It refers to infection of the endocardial layer of the heart. Endocardial layer of the heart. It predominantly affects valvular endocardium is predominantly affected than the rest of the endocardium. Valvular endocardium is predominantly affected. These are the 2 points I want you to mention in the definition. It is infection of the endocardial layer, and it mainly affects the endocardium, which is layering the valves, not the ventricles or atria. When it can get affected there also, but most commonly it affects the endocardium over the valves. Okay. So now what are the causative agents? So when we write about causative agents, try to give a visual representation. Fungi and bacteria are known to cause. Virus we generally do not discuss. So among the fungi and bacteria, bacterial is more common, accounting for more than 98%. Fungal is less common. It is seen in less than 20% of endocarditis patients. Though in the recent times, the number of fungal endocarditis is increasing. Okay. So what fungal organisms are known to cause? It can be Candida. It can be coccidioidomycosis. And in the recent times, we have also started seeing Aspergillus causing endocarditis. But of course, when I say infective endocarditis, we are mostly talking about bacterial. Now, when it comes to bacterial, right, what are the common organisms? So overall, remember here, Staphylococci plus Streptococci. Staphylococci plus Streptococci account for more than 80% cases. More than 80% cases. Staph and Strepto account for more than 80% cases of infective endocarditis. Okay. There are a few extra points to write here. The overall most common cause today, when I was in MBBS, it used to be the Streptococci. Today it is the Staph aureus. Staph aureus is the most common cause for infective endocarditis world over. Okay. Now, if they ask you the right-sided infective endocarditis, what is going to be the most common cause for right-sided infective endocarditis? It's again Staph aureus. Staph aureus. If they ask you what is the most common cause for infective endocarditis in patients who have received a prosthetic valve, the prosthetic valve endocarditis is divided into early and late. Early refers to less than 12 months, late refers to more than 12 months. So if it is less than 12 months, it is usually going to be coagulase negative Staphylococcus aureus. Mainly among them, most common is Staph epidermidis. Okay. And after 12 months, it is the Streptococcus viridans. Streptococcus viridans. So these are the few epidemiological points you should write. If you're not able to remember, at least mention the organisms. Rare or atypical causes. So you're familiar with this term called as HESEC group of organisms. You should be able to write that. These are rare or atypical organisms. Otherwise, commonly it is Staph and Strepto. Enterococci is another group of organisms that you should be familiar. Okay. Now, what clinical features these patients with infective endocarditis present? So remember, because of repeated trauma to endocardium, it is inflamed. On top of that, there will be formation of thrombus, because endocardium is nothing but the endothelium of blood vessel. It is just the extension of that into the heart. So once there is endocardial injury, there will be formation of small clots, and these clots become the culture media for bacteria to come and sit. So if there is entry of bacteria to the blood, and if there is a clot on the endocardium, it will go and settle there and start replicating. Once it starts replicating, the clot will be called as the vegetations. Okay. But the problem is not restricted to endocardium, because the bacteria are now replicating inside these endocardial clots. They are getting released to blood and they are circulating in the blood. That can cause a problem. So because of bacteremia, what features I can get? I can get fever. Fever is the most common symptom that patients with infective endocarditis present. But of course, there is also involvement of the heart, right? Endocardium is heart. Which part of the cardiac endocardium is affected? Valves. So involvement of cardiac, it primarily manifests with valvulitis. Which valve is most commonly affected? Mitral valve is more commonly affected, followed by aortic valve. And what it causes? In the mitral valve, it causes mitral regurgitation. In the aortic valve, it can cause aortic regurgitation. So infective endocarditis is one of the causes for acute MR and acute AR. In both cases, it is going to be acute MR and acute AR. Now, apart from that, if there is an infection, body will produce antibodies against it. These antibodies and the bacterial antigens can combine to form immune complexes. And those immune complexes can get distributed to other tissues, deposit there, and they can cause manifestations. So immune complex deposition can lead to few important manifestations. One of them is Roth spot. Tiny hemorrhages on the retina. We call it as Roth spots. Okay. The second immune complex deposition manifestation is something called as Osler's nodes. Which are seen on the patient's distal parts or apical parts like the palms and soles. Osler's nodes. Apart from that, if let us say this is the atria, this is some ventricle, there is some valve, let us say mitral valve, and the vegetations are formed here. These vegetations contain what? Clot and bacterial colonies. From there, they can get dislodged, come to the blood, they can get embolized, go somewhere, get lodged into some other blood vessel, and then start causing problems in that blood vessel, right? So because of embolization or vasculitis also, we can get some manifestations. What important manifestation that is because of vasculitis that you have to remember? It is the Janeway lesion. Of course, in the exam, you cannot put the images, but at least these Roth spots and Janeway lesions, you can do a rough sketch, make some pointers, label it, and present it. That will be like, okay, quickly examiner will see and he knows that, okay, you know what is Janeway lesion, you know what is Roth spot, you know what is Osler's nodes. Okay. So what is Roth spot? It is the retinal hemorrhages, and generally these retinal hemorrhages will have a central pallor. So what you have to do is draw a small circle like retina, draw a macula, draw some blood vessels, and then you draw some hemorrhagic spots and make sure that you create some central pallor, label it as retinal hemorrhages with central pallor. That is our Roth spot. Okay. Then You have to also try to sketch the image representing the Osler's nodes and Janeway lesions. Okay. What point I want you to write there is just write two lesions. One you label it as Osler's node, the other you label it as Janeway lesion. Point you should write is the Janeway lesion is painless, and Osler's node is painful. Janeway is painless means मेरी जान को पेन नहीं होता है, जान को पेन नहीं होता है. Janeway is painless, Osler is painful. So if you have mentioned this, the clinical features are completed. Instead of just randomly writing the clinical features, if you write the underlying principles, right? Why fever, why MR, why AR, and why rock spots, why Osler's nodes, and why Janeway lesions, that beautifully summarizes the underlying pathophysiology or principles. Now, after the clinical features, there comes the diagnosis of infective endocarditis. Okay. Now, how do we make the diagnosis of infective endocarditis? What is the criteria that is followed for the infective endocarditis? Now, in the examination hall, you can get confused between two diagnostic criteria. One of them is called as revised Jones. Can anybody tell me for what condition this revised Jones criteria is used? And there is another called as modified Duke criteria. One of them is used for acute rheumatic fever and one of them is used for infective endocarditis. So can anybody tell me which one is for the rheumatic fever and which one is for the infective endocarditis? Which one is for rheumatic fever? Which one is infective endocarditis? Okay, let us clear the confusion clearly. So revised Jones is for the rheumatic fever, and modified Duke is for the infective endocarditis. How do I remember it? Just remember radio jockey, right? RJ, radio jockey. So where the rheumatic fever ke liye we have the Jones criteria. Rheumatic fever ke liye we have Jones criteria, radio jockey. Whatever is left is for the infective endocarditis. So the criteria that is currently followed is modified Duke criteria. Modified Duke criteria. Modified Duke criteria. So let us look at what is included in the modified Duke criteria. You don't have to exactly replicate how is it represented here in the image that I'm going to share. Just be able to write the main headings. So modified Duke criteria, as you see here, we have major criteria and minor criteria. There are only two major criteria: blood culture and evidence of endocardial involvement, mainly from the echocardiography, or the presence of mitral regurgitation or aortic regurgitation. So blood culture, evidence of endocardial information, evidence of endocardial involvement. So you can remember it with a simple mnemonic B, right? B as you are, B. Blood culture, evidence of endocardial involvement. These are our major criteria. What are our minor criteria? Presence of predisposing factors, presence of fever, presence of vascular phenomenon, which we have discussed, right? Vasculitis or embolization giving rise to the Janeway lesions. Then immunological phenomenon, microbiological evidence of the infection. So what I want you to elaborate is what is considered as blood culture positive infective endocarditis, right? When do you say that the blood culture is positive for the infective endocarditis? This is what examiner is looking for in the question. Otherwise, he knows that he will be able to memorize or mnemonics to write the criteria. So blood culture is said to be positive for infective endocarditis if you have isolated typical organisms. What are our typical organisms? Staph aureus, streptococci, right? Typical organisms. Then at least two or more than two cultures should be positive. But if you are isolating atypical organism, the HESEC group of organisms, in that case, more than two blood cultures taken 12 hours apart should be positive. So for typical organisms, we have not defined whether they should be taken 12 hours apart. Two cultures positive, done. Only one, no. Two positive, blood culture criteria is satisfied. But if it is atypical organisms, you need two or more than two cultures positive which are separated by 12 hours. Like I have taken one sample in the morning 6 a.m. another sample after 6 p.m. Both are showing that atypical organism. Well, then blood culture is positive. If one is showing but the other is not, then the blood culture criteria is not positive. Or 3 to 4 separate blood cultures taken in quick fashion, but the first culture and the last culture should be separated by 1 hour. Like, okay, I take one culture now. After 30 minutes, I take one more. After another 30 minutes, I take one more. After another 30 minutes, I take one more. Now I have 3 cultures and they are all positive. The time difference between the first and the last is 90 minutes, more than 1 hour. So then it is satisfied. And for one particular organism, that is Coxiella burnetii, right? For Coxiella burnetii, even a single blood culture positive is considered as satisfying the blood culture criteria. So blood culture is said to be positive if 2 typical organism cultures are positive, or 2 atypical organism cultures are positive which are taken 12 hours apart, or 3 or 4 atypical organism cultures are positive where the first and the last culture is separated by more than 1 hour. And if it is Coxiella burnetii which is positive in the culture, even a single positive culture is satisfying. Okay. Second, from where I get the evidence of endocardial involvement, it can be either in the form of patient presenting with acute MR or AR, or it can be echocardiographic evidence of the presence of endocardial involvement. These are major criteria. The mnemonic for major criteria, as I have already told you, it is B, Bachelor of Engineering, B for blood culture, E for the evidence of endocardial involvement. You can simply sum it as echo. Minor criteria are predisposing factors. So what are the predisposing factors? Patients having valvular heart disease, or congenital heart disease. These are considered as predisposing factors. That's a minor criteria. Having fever 38 degrees is a minor criteria. Vascular and immunological phenomenon, which we have already discussed, right? Vascular phenomenon, immunological phenomenon, that is presence of Roth spot, Osler's nodes, or genuine lesions are minor criteria. And then last is microbiological evidence. What do I mean by that? Evidence which does not fit to be called as positive for the blood culture. For example, I got staph aureus positive in one culture, but the second is negative. So it is not fit to be called as a major criteria, but it will still go as a minor criteria. So cultures which do not fit to be called as major will be considered as minor. Then how do I make a diagnosis? A definitive diagnosis of infective endocarditis is made when 2 major criteria are present, or 1 major and 3 minor are present, or 5 minor. There are only 5. They are all present. Then we will call it as definitive infective endocarditis. Okay. So that is our diagnostic criteria. Once we have diagnosed the infective endocarditis, then comes the question of management. Management is to be guided by culture. I want you to mention this word there, that management is to be guided by culture. It's not like, okay, I have diagnosed infective endocarditis, whatever antibiotic comes to my mind, I'll get. Based on what organism is isolated on the culture, we choose the antibiotic. So if it is the staph aureus and it is the native valve endocarditis, means patient is not a patient of prosthetic valve. In that case, we go for Rohina, I forgot to mention. Yeah, even presence of prosthetic valves is a predisposing condition. Prosthetic valve. Then even IV drug abuse is also a predisposing condition. Okay. So if it is a native valve, patient is not having the prosthetic valve, in that case, vancomycin is enough. But if it is MRSA and patient is having prosthetic valve, then we treat them with vancomycin plus gentamicin. Vancomycin plus gentamicin. Okay. If it is Streptococcus viridans, thankfully it is still sensitive to penicillin, so we treat with the penicillin G. Penicillin G. If it is enterococci which is sensitive to penicillin, of course we will treat it with penicillin G only because it is sensitive. If it is penicillin resistant, again we treat it with vancomycin plus gentamicin. So in infective endocarditis, there is a lot that you have to memorize. So spend some 10 minutes trying to memorize the points that we have discussed, because it is not about concept, it's more about memory. The criteria, cultures, organisms, and antibiotics you have to memorize. Okay, so that's about infective endocarditis. If you are able to get 60% of the points we discussed, you will definitely get 3 to 4 out of 5 marks that the examiner tends to give you. Okay. So now we will move to the next question. The next question that we have is on heart failure. I'll try to wind up in next 10 to 15 minutes. Heart failure is generally a 10-mark question for most university papers. Of course, not everything about heart failure will be addressed in 10 marks. Instead, what they will do is they will break it. Okay. So they might ask you to define heart failure, which carries 1 mark. They may ask you to describe the role of biomarkers in diagnosis of heart failure, that carries 1 to 2 marks. Then they will ask you to classify the heart failure, for that they give 2 marks. Then they will ask you about the management of heart failure, that carries 4 to 6 marks. Okay. So now we will begin with the definition. So what is heart failure? So heart is supposed to do 2 functions. One, receive the blood from the peripheries, means right side should receive the blood from veins, left side should receive the blood coming from the lung. Receive the blood and then eject. So when hearts receive the blood and fill the ventricle, that phase is called as ventricular filling. And when they contract and eject the blood to distribute to the tissues or the lungs, we call it as ejection. So heart failure is defined as impaired ventricular filling. Either ventricle is not able to fill, impaired ventricular filling, or impaired ventricular ejection. Impaired ventricular ejection. Now we eject the blood from the ventricles during systole. So if it is impaired ventricular ejection, you can call it as systolic heart failure. It is called as systolic heart failure because we eject during the systole. And if it is impaired ventricular filling, we are not able to fill the blood into the ventricle, then we will call, because we fill the blood into ventricle during diastole, we will call it as diastolic heart failure. So to summarize again, ventricles receive the blood during diastole. So if they are stiff, they are small, they are not able to receive the blood during diastole, then the filling won't happen. It is diastolic heart failure. If diastole goes well, then we eject that blood into the arteries during systole. If I am not strong enough to eject the blood, I fail. Then it is systolic heart failure. This is the basic definition. Okay. Now, how do I classify the heart failure? So, classification of heart failure is of 2 types. One is based on which side of the heart is being affected by heart failure, whether it is right side of the heart or the left side of the heart. So we can classify into right heart failure and left heart failure. So we are supposed to write few features describing the right heart failure and left heart failure. So what clinical features I get if it is right heart failure, and what clinical features I get if it is left heart failure. Clinical features and causes. Okay, so to understand that, I'll just take 2 minutes to brief you what heart failure stands. So let us say this is heart. I have a right side, left side. From the left side, I eject the blood to aorta. From the right side, I eject the blood to pulmonary artery. The pulmonary arteries take the blood to lungs, right? And this takes the blood to tissues. Right side receive the blood from superior and inferior vena cava, and left side receive the blood from the lungs through what we call as pulmonary veins. So whenever my right side of the heart fails, right, I'm either not able to eject this blood into the pulmonary artery well, or I'm not able to fill the blood into the right ventricle. What happens in that case? Pressure inside the right atrium starts building up. Why? Because blood is coming to right atrium, but I am not able to fill it into the ventricle well, or I am not able to eject it to the pulmonary artery well. If I am not able to eject it well, it will stay back in the ventricle. If it is staying back in the ventricle can't receive more. Again, pressure in the right atrium will build. Same problem with the left side. So if I have left heart failure, pressure in the left atrium increases. So if the pressure in the left atrium increases, it will start causing impairment to the flow of blood from pulmonary veins to left atrium. On the left side, if there is right heart failure, there will be impairment of flow of blood from superior vena cava and inferior vena cava to the right atrium. So then the blood will start getting congested in superior and inferior vena cava for right heart failure and pulmonary veins for the left heart failure. Eventually what happens is congestion will start affecting the lungs because the blood from lungs itself cannot reach the pulmonary veins easily because pressure in the pulmonary veins is already high. Same applies to right. So if the pressure in the right atrium is high, superior and inferior vena cava pressure will become high, and in that case my JVP will start getting increased because the pressure in the JVP also starts increasing. And remember, the blood from the liver drains into the inferior vena cava. If the pressure in the inferior vena cava is high, I cannot drain the blood from liver. Blood will start stagnating in the liver. So whenever I have right heart failure, where is the congestion happening? Jugular veins and liver. Whenever I have left heart failure, where is the congestion happening? Pulmonary veins and lungs. So those will lead to the symptoms. So right heart failure presents with raised JVP, hepatomegaly. Hepatomegaly will result in pulmonary hypertension that will result in ascites and development of edema. If I have left heart failure, the congestion will be in the lungs. So that will result in dyspnea, orthopnea, shortness of breath on lying down, and then shortness of breath after some time of going to sleep called as paroxysmal nocturnal dyspnea or PND. What can cause the right heart failure? The most common cause for right heart failure is left heart failure. Because if the left heart fails, the pressure in the pulmonary vein increases, lungs increases, eventually pulmonary artery pressure increases, then right heart also fails. Okay. What else can cause the right heart failure? Cor pulmonale. Cor pulmonale. What is cor pulmonale? Pulmonary hypertension because of lung disease resulting in right heart failure. Okay. What are the more common causes for the left heart failure? Hypertension and ischemic heart disease. Hypertension and ischemic heart disease are more common causes for left heart failure. So this is one classification. Then we also have a second classification, that is classification based on ejection fraction. Classification based on ejection fraction or EF. Now before you even write down the classification based on the ejection fraction, I want you to write down what is EF. We have to mention what is EF, then we can discuss more. Rohina, Rashid, yes. Cardiomyopathies can cause both right as well as left heart failure. So hypertrophic cardiomyopathy causes left heart failure. Restrictive cardiomyopathy causes right heart failure. Collectively, yes, dilated cardiomyopathy causes left heart failure. Before we even classify the causes for heart failure, we have to mention first what is ejection fraction, right? So we have to mention the formula for ejection fraction. What is ejection fraction? Stroke volume divided by end diastolic volume into 100 to express it in percentage. It refers to ejection fraction. Now what is that? It basically means, if let us say this is my left side of the heart, okay, now I transfer the blood to this ventricle during diastole, right? I fill some amount of blood, and once the diastole is over, the ventricular filling is over, now I have blood in my ventricle, I'm ready for the next systole. Diastole is just over. So whatever blood I have in my ventricle at the end of diastole, we will call it as end diastolic volume. Now this ventricle will contract and eject some amount of this blood during next systole, but it cannot eject all of this blood. Some of this will be ejected, and whatever the blood that gets ejected, right, we will call that blood as stroke volume. And in mathematical terms, what percentage of end diastolic volume got ejected at stroke volume, that percentage is what we call as ejection fraction. So that is why the formula is stroke volume divided by end diastolic volume. So the normal ejection fraction is roughly in the range of 60 to 70%. And what is the single most important determinant of the ejection fraction? It is the force of contraction of your ventricle. The more strongly it contracts, more amount of or more percentage of EDV will be converted to stroke volume, right? Let us say I have 200 ml of blood in my ventricle. If I generate more force, out of this 200, I will be able to eject 160, 170. If I generate less force, I will be able to eject only 100 or 80. So the single most important determinant of the ejection fraction is the force of contraction of the ventricle. When ventricle can contract well, when it is strong and it is getting sufficient blood supply. If I have, say, let us say I have ischemic heart disease and I'm not giving blood supply to this area, can my ventricle generate strong force of contraction? No. So in that case, the stroke volume generated will be less. So ejection fraction will be less. So whenever I have impaired contraction of the ventricle, EF will be less. If I have heart failure without impaired contraction, then EF will be normal. Okay. So based on the ejection fraction, we classify the heart failure into two major categories: heart failure with reduced EF and heart failure with preserved EF. Heart failure with reduced EF and heart failure with preserved EF. Ejection fraction is not lost much. So when EF is less than 40%, we call it as heart failure with reduced EF. When EF is more than 50%, we will call it as heart failure with preserved EF. And when ejection fraction is in the range of 40 to 50, we will call it as heart failure with mid-range ejection fraction. Heart failure with mid-range ejection fraction. Okay. So when EF is less, it is equal to systolic heart failure. Systolic heart failure. And when EF is good, means force of contraction is good. So systole ejection is not a problem. Patient's heart failure is because of impaired filling. So that means we have diastolic heart failure. If you want, you can write the most common cause for heart failure with reduced ejection fraction is IHT. The most common cause for heart failure with preserved ejection fraction is hypertension. Hypertension. Okay. Now we have studied classification of heart failure, right versus left, and ejection fraction based classification. Okay. So after the classification, what are they asking? They are generally going to ask about the biomarkers for the diagnosis of heart failure. So let us write about diagnosis of heart failure. How do we make a diagnosis of heart failure? So diagnosis of heart failure is based on two things. First one, signs and symptoms of heart failure. Signs and symptoms of heart failure. So what are we talking about? If it is right heart, raised JVP, hepatomegaly, ascites. And if it is left heart, the orthopnea, PND, dyspnea, right? These are the signs and symptoms of heart failure. If they are present, along with that, if there is elevated biomarkers, then you can diagnose it as heart failure. Now, what is the biomarker I'm talking about? Can I have raised JVP without heart failure? Yes. If there is a right atrial obstruction or there is a tumor in the right atrium, I can have raised JVP. Can I have hepatomegaly without heart failure? Yes. If I have some storage disorders affecting the liver, or if I have hepatitis, I can have, right? Can I have orthopnea without the heart failure? Yes. In conditions like massive obesity, massive ascites, we can have. So that is why now I have to link these heart failure symptoms to heart with the help of a biomarker. So I just showed you an image, right, where I had sketched an image and showed that whenever heart fails, pressures inside the atria increase. And whenever atrial pressure increases, they send a signal molecule to kidney saying that there is too much pressure on us. Please relieve us of this pressure by excreting urine, extra urine. You lose more urine, pressure on us will come down. That signaling molecules are called as natriuretic peptides. So if they are increased, then it is a case of heart failure, because they will be increased only when atria and ventricles are getting stretched by the pressures. So the role of biomarker is elevated, increased natriuretic peptides, mainly pro-BNP, that is B-type natriuretic peptide, or a precursor of it called as N-terminal pro-BNP. So what you can write as a statement: natriuretic peptides mainly BNP, pro-BNP or N-terminal pro-BNP are used as biomarkers for diagnosis of heart failure. Biomarkers for diagnosis of heart failure. Okay. So that gives us one more mark. So now we have written about the diagnosis. Now what is the role of echocardiography? Role of echocardiography is for classification into reduced ejection fraction or preserved ejection fraction, not for the diagnosis. Clinical symptoms plus elevated biomarkers, we have the diagnosis of heart failure. Okay. Now after the diagnosis, what are they asking? Classification is done, biomarkers and diagnosis is done. Now it is briefly about management of heart failure. Okay. So how do we manage a patient with heart failure? I will give you a brief algorithm with a little bit of note on the pathophysiology, because management is linked to pathophysiology of heart failure. So what happens in heart failure? Heart failure is characterized by neurohormonal alterations. Neurohormonal alterations means when heart fails, some neurological and hormonal changes happen that cause more harm to the patient. So what happens? So if there is heart failure will be associated with decreased stroke volume, or you can also say cardiac output. Because of that, it will result in decrease in the BP. I want all of you to remember that your blood pressure, especially systolic BP, is directly proportionate to stroke volume. Higher is the stroke volume, higher is the systolic BP. If heart is ejecting less amount of blood, your BP will be less. So when this BP decreases, body will try to counter it by activating two important mechanisms. So what are those mechanisms? The first one is your sympathetic nervous system, and the second one is your RAS. Sympathetic nervous system gets activated whenever your BP is less, and the second one is renin angiotensin aldosterone system. So what sympathetic nervous system will do? Of course, adrenaline will act through its receptors. What are those? Alpha receptors, beta receptors. What it will cause? It will cause vasoconstriction. By causing vasoconstriction, it can increase the BP. So it is a response to decrease in the BP that is happening in heart failure. What second thing? RAS. So RAS will produce angiotensin 2 and aldosterone. What angiotensin 2 will do? That will also cause vasoconstriction. Right? Now, is this good for the heart? No, unfortunately, no, because your heart is failing because it has either hypertension or it had the ischemic heart disease. And a failing heart, now once the blood vessels are constricted, it has to push more effort to push the blood into constricted blood vessels. Right? Now, if I connect a pipe to this bottle and I press it hard, the pipe is compressed. I have to put more effort to squeeze the blood into those constricted pipes. If the pipe is open, it is more easy. So vasoconstriction increases the work of the heart, right? It increases what we call as afterload. And increase in any work for the heart when it is failing is more dangerous. Now, can aldosterone do something good for the patient? Unfortunately, no. What aldosterone will do? It will increase sodium and water absorption by kidneys. So we have more sodium and water, right? That will increase again the circulating blood volume, and this will result in increase in preload or more blood in the heart, right? Both of these are harmful. They will worsen heart failure because any load on the heart is dangerous. Okay. At the same time, heart failure also activates one more mechanism, that is, there will be activation of natriuretic peptides, because heart failure results in increase in atrial or ventricular pressure, and because the pressures in the chambers are getting increased, they will produce natriuretic peptides, that is ANP and BNP, and this ANP BNP will stimulate the kidneys to excrete instead of reabsorb, sodium and water excretion. By doing so, they are decreasing the load on the heart. Preload gets decreased, right? So this is beneficial. This is beneficial. So one side, one pathophysiological change is unburdening the heart, the others are burdening the heart. So now if I have to manage this patient, what should I do? I have to make sure that this vasoconstriction, sodium and water reabsorption of the kidney is all blocked, right? And on the other hand, I have to facilitate the activity of the ANP, BNP so that I get the extra benefit of the beneficial adaptation. So that is why whenever it comes to management of heart failure, how do we manage? What I have to block? I have to block RAS. It is harmful, right? Angiotensin receptor or angiotensin formation I should block. Aldosterone activity I have to block. So how do I achieve that? By giving AC inhibitors or ARBs. That is one class of drugs I can use. Second, what I can use? Spironolactone. What is spironolactone? Spironolactone is a aldosterone receptor blocker, right? It's a mineralocorticoid receptor antagonist or aldosterone receptor blocker. So spironolactone will block this. Then AC inhibitors or ARBs will block this. That will help me to cut off the harmful changes that are happening. Okay. Then third, for a patient with heart failure, we also give beta blockers. Why are we giving beta blockers? Because beta blockers reduce the force of contraction of the heart. By reducing the force of contraction, they reduce the work done by the heart, which is good for a failing heart. They also decrease the heart rate. By decreasing the heart rate, again, they are reducing the work done by the heart. Okay. Fourth, there is a new class of drugs called as neprilysin inhibitor. Neprilysin inhibitors. Now, what are these neprilysin inhibitors? So remember, once ANP, BNP is formed, it gets broken down to inactive peptides by an enzyme called as neprilysin. Neprilysin. So if I block this neprilysin, ANP, BNP will act longer. It will make you excrete more sodium and water and reduce the burden on the heart, and it will help the failing heart. So examiners expect you to write the example. Currently, only one drug is available in India, which is called as sacubitril. Sacubitril. Okay. Then newly we have SGLT2 inhibitors. Example, gliplozins like empagliflozin or dapagliflozin These are SGLT inhibitors. These are also used for the treatment of heart failure. Okay. In a prof exam, you don't have to elaborate in detail the protocol or the principles behind the use. If you're able to mention the list of drugs and one example for each, it's generally accepted more than adequate until and unless they want to give full 5 marks for the management itself, which is unlikely in most university scenario. Okay. Now, you have to also mention something called as ARNI. So what is ARNI? ARNI refers to combination of angiotensin receptor blocker or ARB plus neprilysin inhibitor. So when we give it in combination, we call it as ARNI. So it is ARNI refers for angiotensin receptor and neprilysin. Both are being inhibited. Angiotensin receptor and neprilysin inhibitor, right? So example for that, we have one approved combination, which is valsartan as ARB, valsartan plus sacubitril as the neprilysin inhibitor. Okay. Now, where is it indicated? Do I give it for all patients? No, it is indicated for heart failure with reduced ejection fraction patients with EF less than 35%, right? This is about our management of heart failure. So you can also beautify your answer when you write pathophysiology, right? You can also mention that, okay, this spironolactone is blocking the aldosterone, right? AC inhibitors or ARBs are blocking the angiotensin 2 activity. Then your beta blockers are blocking the sympathetic nervous system activity. Then sacubitril is blocking this neprilysin activity. So this way we can beautify our answer when it comes to the exam. Last thing, why we are giving SGLT2 inhibitors? SGLT2 inhibitors increase the urinary loss of glucose. Because of that, it also increases or exerts some diuretic effect, and thus it reduces the preload, decreases the BP, reduces the cardiovascular mortality. Okay. So last note I want you to mention is drugs that reduce mortality in heart failure patients, drugs that reduce mortality risk, and drugs that increase mortality risk. Increase mortality risk. So what drugs decrease the mortality or death risk? Of course, anything that calms down this harmful adaptation or anything that facilitates this beneficial adaptation decreases the mortality rate. So AC inhibitors decrease, ARBs decrease mortality, beta blockers decrease mortality, right? Then ARNI or neprilysin inhibitors decrease the mortality. Even SGLT2 inhibitors decrease the mortality. What increases the mortality? Digoxin and other inotropic agents, because these inotropic agents increase the force of contraction. They are kind of opposite of what beta blockers do, right? Beta blockers reduce the force of contraction, slow down the heart. Digoxin increase the force of contraction. Already a failed heart gets more burdened by digoxin and it fails much more faster. So that is why they are associated with increased death risk. So when we write this, our answer for the heart failure is complete. Quick reiteration, what you should include. Definition should include two terms. The first term is impaired ventricular filling. Second term is impaired ventricular ejection. Right? That is our heart failure. Classification include two classifications, right versus left, and ejection fraction based classification as reduced ejection fraction and preserved ejection fraction. Diagnosis mentioned that there should be signs and symptoms of heart failure and it should be confirmed as heart failure when the biomarkers, that BNP or pro-BNP, are elevated. In terms of pathophysiology, there are two changes happening. One, drop in BP activating something, and second, atrial ventricle getting stretched activating something. One is harmful, one is beneficial. Mention that. Try to beautify by linking with the pharmacology. In the management, mention the list of drugs available. Write one or two sentences about the ARNI, and then mention which drugs are associated with reduced mortality and which drugs are associated with increased mortality. For a prof exam, this suffices. If you are preparing for the NEET PG, of course, they will also ask you about the role of left ventricular assist device, the surgery, cardiac transplantation, then cardiac resynchronization therapy, pacemakers. For a prof exam, it is not required and you don't have to even write. And I have not seen any university paper where they are going in such details. Usually at PG exams, we ask them to elaborate the indications and role of cardiac resynchronization therapy or ICD in a patient with heart failure. You have to don't bother about it. Okay, so this is about the today's topics. In the cardiology part 2, we will discuss about the questions from valvular heart disease, rheumatic fever, and pericardial diseases and cardiac. So I'm signing off for today. I'll see you in the next class. Till then, bye. Okay. Yeah, Harshit, even the neuro topics will be covered. I think the whole medicine will be completed in the Jan itself. Okay, so that's it for today. I'll see you in the next class. Till then, bye-bye. The notes will be available on the app as well as the PW MedEd Telegram channel. See you guys. Bye. Harshita, I will cover it. I will cover it before the Jan end. Thank you. Thank you.